Because I remember having this lecture a few times, and then and still when I was preparing, I was like, what's going on? And then of course maybe Netta can shed some lights, in the middle, because because whenever, I don't know. I don't know about you guys, but pretty much after step one, like, those nuclei, it's like rough out or whatever, SCN, they are kind of out the door. But I want to make sure that the sleep, we gotta know the basics of it, and then we gotta kind of have an idea of, how things work, and then because a lot of these, not only that these neurotransmitters are important, and understanding these neurotransmitters help us to kind of, in my experience, think outside the box a little bit to what kind of medications can I possibly be using to help my patients, and what might be keeping them awake, etc., and stuff like that. And those ones, if we continue to just memorize a big list of medications that may or may not cause sleepiness, or may not be causing your disturbance in sleep, it's a laundry list of things, and then it doesn't even cover everything, not even remotely close. So everything could be possible there. Let's see, chat one. Oh, hello. Okay, good. Okay, good. Perfect. So it's me, and yeah, I'm just kind of throwing some things in there, which you guys already know. Let's see. It'd be nice if we can turn to the next page. It would be nice if we could turn to the next page. Okay. So this is a big thing, right? So the Poland process model. And quite honest with you, for the longest time, I was trying to map out this guy to a shape of a C, and mapped out that guy in the shape of an S. And I could not do it for the life of me, because I did not read this line. S equals to sleep, and C equals to K. Okay, so basically that's process C and process S, process sleep and process occasion. They oppose each other, and then this is what we have found. Basically, we will come back to this at some point later on in this presentation, but process S really is for you building up your sleep burden. And as you sleep, you replenish them. So it's a very straightforward boom, shoom, boom, shoot, day in, day out. It's like that. And with the process C, it's circadian that kind of goes with the alertness level and stuff like that. It actually always kind of, when I look at this, I'm always in out of how come our most alert time. Suppose that your nighttime sleep is from 12 midnight to 8 o'clock in the morning. Suppose that's our time. And our most alerting time is between 6 to 8 p.m. And as Dr. Kyo Rosen used to say it, I can't remember the exact word that she used, but basically it's describing that that's the forbidden zone. Yes, it's the forbidden zone. That's the part where you're not supposed to be sleeping. But no, like that's right after dinner. That's when I'm like passing out. So, potentially our circadian rhythm, residents, fellows, and stuff like that, medical professionals, probably a little bit forward compared to this particular model here. So, our most alertness could potentially be between 4 to 6 p.m. or 5 to 7 p.m. and stuff like that. But I guess everybody is different. And then we might be having some kind of ideas about like, these ideas are really, it also is dependent on the process S, right? If we're able to have a good amount of sleep every night, are we going to feel that good amount of alertness between 6 to 8 p.m.? So they're opposing each other. The circadian rhythms, they're not really, in the majority of it, it's regularly, but like primarily, but our process as the sleep part, basically it's, you gotta sleep, you build up the sleep burden, and then you go down. Okay, but we'll come back to this in a little bit. So risk for joint driving, just something to think about. From a study back in 1995, with the most amount of crashes, around like 7 or 8 in the morning. And then there's another peak right here around 4 or 5 p.m. And if you look, oh, there, you're least alert, and you have that dip in alertness. It's pretty interesting how things work out that way. Did you know that in 2017, the Nobel Prize for Medicine and Physiology actually went to 3 guys who basically discovered the molecular basis of circadian rhythm? I actually just learned about that last night. It's quite interesting. And then they did their research on fruit flies with genes that are pretty interesting. So with sleep, neurobiology, you're gonna kind of look at our normal hypnograms and stuff like that. This is what we see. You see there in probably about a 90-minute cycle 4 or 5. You start with stage 1, then 2, then 3. But obviously with over here, on the light of it, these proportions are disproportionate to the actual amount, because stage 2 should really be about 50% of our entire night. And whereas these ones there are, you can just imagine all of them being a little bit shorter. Stage 3, stage 3, stage 3. And then stage 3 goes shorter and shorter as the night goes, whereas it's longer and longer as the night goes. That's kind of always known. And then that's actually, frankly, the reason why a lot of times you find that in the morning when your alarm, goes like, oh, I just woke up in the middle of my dream. It's more likely that to happen because you have the most memory on that as well. All right, so a quick recap of this good old brain, right? And then, so if we look from the top left, the prefrontal cortex, wakefulness, attention, behavior, flexibility, cognitive control, and then you have a hypothalamus, which is really responsible for your awakeness, stress response, your basal forebrain, probably your wakefulness, amygdala, hippocampus, episodic emotional and memories, thalamus, sensory processing, wakefulness, stress detection and pain modulation. Your midbrain over here also has something to do with your wakefulness, sensory cortices, and the cerebellum, the motor functions, and then of course with the spinal cord down here connecting down, motor and sensory function during sleep and wakefulness, and that is also particularly important, right? Because during REM sleep, something happens. So we have that signal going down, and which consequently we have a paralyzed state of our skeletal muscles. So going down, today we're hoping to cover the assessment of sleep-wake states, characteristics of wakefulness, physiological regulations of sleep-wake states, and some neuroanatomy and neurobiology, neurochemicals control sleep-wake states. But again, I'm formulating this really on the basis of how can we understand and remember these in a much easier fashion, okay? Especially for you to be able to use that in your clinical encounters, especially reading and also reading and interpreting your sleep studies, and just kind of understand how things generally work. And if we have this coupled with Dr. Gendotra's lecture on insomnia and medications and how different receptors and stuff like that, that would be a very, very nice combo between the two. Okay. So overview, what does sleep do for us? Ecological, environmental advantages, and then sleep happens best at night. So during the day, you got the sunlight to help you and to do things, improve the quality of wakefulness, alertness, mood, cognitive, integration of experience and learning, resensitization of receptors, metabolic inflammatory effects that happens during the night when you're sleeping, and supposedly longevity. Sleepiness and sleep deprivation. Some of these studies were done in the past about, if you start to see, this is the baseline where everybody's mean sleepiness scale is at, and day 1, day 2, day 3, day 4, day 5, day 6, their sleepiness, obviously, the more they are sleep deprived, this is, they still have 9 hours, 7 hours, 5 hours, and those subjects with only 3 hours of sleep. And of course, you're sleep deprived for that long, you're going to be crazy sleepy, and your recovery day 1, day 2, and day 3. And you can also performance and sleep deprivation, as you can see, with the more sleep deprivation accumulation and stuff like that, you have more number of lapses. Basically, they were doing experiments and then they could not perform the test. Obviously, you're sleep deprived. Every time you talk about what's going on, and you look at your attending, you're like, I'm sleep deprived. And then they say, hey, you do sleep medicine. I'm like, well, you still get to be sleep deprived even if you have sleep medicine done, right? Next one, sleep deprivation effects on cognitive functions, functional MRI with normal sleep activation of prefrontal cortex, parietal and parietal and premotor cortex. Following sleep deprivation, basically you don't see really much stuff lighting up, nothing right. So that's that. And sleep deprivation in medical trainees. So various different studies back in the days, surgeries. 20% more error and 40% more time required to perform simulated laparoscopy, post-co, a couple of studies, internal medicine residents also, they have issues like that. And then pediatrics, time required to place an arc line increased significantly in sleep deprived trainees. Actually, speaking of which, I need to do something real quick here. Can I share my screen? Share sound. All right, because we will need that in a bit. Okay, and next. So if effects of sleep deprivation on mood in medical students, that was a study back in 2004. I found this very, very interesting because average of hours of sleep per night, and of course, more conflict with medical professionals that the rating, the lower is worse. Misjudgment on patient care and hours work too long, But moodier and more short-tempered, regardless of their sleep, it's all about the same. And I guess it's just the idea of being a resident. So, or medical residents, yeah. So sleep duration and body mass, the less you sleep, it's interesting studies that they have over here that you tend to be a little bit on the higher side. And you can see with the relationship with leptin and ghrelin, okay? So this is satiety, right? No, which one is satiety? This is the drive to eat. This is satiety. Yeah, leptin is for satiety, ghrelin is for the drive to eat. Yeah. So you got that. So metabolic part also plays a lot in the role into your sleep duration specifically. Assessment of sleep-wake states. So we got self-report questionnaires, we got diaries, we got their own ratings, which oftentimes is unreliable, right? And then we got actigraphy. Also, we got the PSGs that we could use. So those are the couple of things. Can you think of any other things that you ask people about their sleep? How much they sleep and stuff like that. Besides this.
Which they spend in bed, not sleeping.
Right. How much time they spend in bed, but that's also a big part of the observer rate, kind of self-reporting, right? What else can you kind of do besides actigraphy now? Fitbit, right? In some sense, it's very similar to activity. What else? It's like all over the place on the market. Apple Watch, right? That's a big one, which is similar idea to Fitbit. And there are even apps that you can use just on your phone. They observe the noise as well as the ambience in the room, and then try to figure out how much you sleep. I thought those were kind of interesting. Actually, in real life situations, I think sometimes I have tried to ask patients to download an app and basically just go from there. And at the same time, document sleep patterns and hopefully to do that. And of course, in the best case scenario, if we could have activity going on, and that may be potentially the most accurate, but every different institution is different. Metro has activity, VA has activity, but UH unfortunately doesn't have activity. Not at this time. hopefully we'll be able to get some in the future. But as an surrogate or alternative, I have tried to ask patients, even without Apple Watch, to do that. But the caveat for that is that once you do that, I don't want you to look at it. I want you to bring it back to me so that we can discuss it together. Because a lot of sleep patients, especially, they are very sensitive about, doc, I'm not getting enough, deep sleep. And then you ask them, it's like, what is deep sleep? Like, it's deep sleep. It's the sleep that you're supposed to get. I was like, do you know how much deep sleep are you supposed to get a day? So that's also the question, how much are you supposed to get a day? Is that, well,
You're asking me
yeah.
how much deep sleep?
Yeah. Or first of all, what's the definition of deep sleep? What is deep sleep? Because this, we heard a lot, right, from our patients, or not? Have you heard it from the patients?
Yeah, a little bit.
Yeah.
Not a lot, but if you're talking about like N3 or what?
Right, that's frankly there, right? The N3, the deep sleep, the slow wave sleep, right? And then how much of that are we supposed to get?
Probably comprised.
So we have, let's say 7 to 9 hours, right? And N3 is 20%, right? So 20% times 8 is probably about 1.5 hours, 1.5 hour a night of deep sleep, maybe, approximately, lower area, basically between 1 to 2 hours. And so one patient, there's a patient that comes in and say, doc, I only have 90 minutes of deep sleep last night. This is bad. I said, well, this is perfect. What are you talking about? A lot of times these misconceptions, they tell you deep sleep on Apple Watch, on Fitbit, but they don't tell you what's normal for deep sleep. A lot of times they don't know. And then how accurate is that deep sleep? Of course, we don't know. Yeah. But it's a good thing to kind of know what patient you have on hand, and then and what relates to you and how you react to that, right? Instead of saying no, your Fitbit or Apple Watch is completely inaccurate. I'm done. I kind of tried to do that once and backfire. Didn't so well. So next, sleep diary. You can see an example of people who have it, and the baseline. They kind of highlight out what they have. Speaking of which, I also have just had a patient who left his sleep diary with me. Yay, like that. So it's actually a sleep diary. I believe he was given the sleep diary from Cleveland Clinic, and then he's just a professor / scientist himself. Was one of the first computer science professors, I think. Anyway, and then so he did a really good job at it for it, but this is real documentation of it. Whereas most of the things that we see right now, and with your experience with Dr. Abraham and Pete, especially, you probably hand out the sleep log quite a bit and want them to do that. Have you guys had a chance to review anyone? Patients bringing in, and then you actually look at the sleep diary and you kind of figure out what's going on. That's also interesting. And then what I have learned during my fellowship was that we often ask them to, take a picture of it and send it back in 2 weeks. And then when they send it back, they'll send it back to Jen, and hopefully you talk to the, Jen, Becca, Brady, or whatever, and then have them make sure that they forward that to you as well. So do your own little review, pull up their chart and say, oh, this is what's going on. I thought she might have this, might have that, might have that. Bam, I got it, and here is what we're gonna do next. Reviewing those sleep diaries is also very crucial, instead of just giving it to them, right? And then afterwards, they might, post-intervention with some CBTI or whatever, so much better. Before it was more like irregularities and going down with post-interventions. Actigraphy is more objective finding and use that against your subjective understanding of what's going on, right? So got that. And I remember Dr. Lockley showed me a sleep diary. What was it, Dr. Lockley or Dr. Park? I can't remember. But it was interesting. With that, you can see people, patients writing down very, very meticulous details on things and all that. And that also gives you a little idea as to how you approach with the certain patients. As you can see, with about now 6 weeks of fellowship under your belt, sleep is a very, very somewhat, some straightforward cases for sure, right? Just like how we do in feminists or even in home or neuro clinics, there's straightforward cases, boom, come in and out. But there are ones that are just so complicated that you have to really dial in from all facets of approach, and psychologically that's one of the major approaches that you need to take to how to establish that patient relationship and kind of get it into it. So actigraphy for the objective finding, a lot of times we just need to see it, what really is going on, and then kind of go from there. So those are kind of the assessments of what's going on that we use often. And then characteristics of wakefulness, non-REM and REM sleep, fairly interesting. We'll also use a couple snippets from sleep studies and just kind of have a little, not really a refresher, but really you guys can kind of self-check at this time how you're doing with your readings and stuff like that. So during wake, non-REM and REM, obviously arousability during wake is high, non-REM is lowest, REM is low, and you can see that with the EEG amplitude. Non-REM sleep, you have a high voltage but slow frequency, right? Slower, and then mixed with fast REM but with the low amplitude. Wakefulness is that muscle tone variable. You start relax REM, your muscle tone is supposed to be as eye movement, voluntary, infrequent, rapid. Infrequent, or you do see more of a like slow eye movement as well. Instead of REM, you have SEM, right? Heart rate, blood pressure, all that, everything. Full, lower, lowest in O2 and CO2. Thermal regulation, all that, mental activity, story like dreams, which is very, very interesting. Do you know when was REM sleep discovered? Around. Well, yes. Get an M&M if you get it right. I only need a decade, like in the somethings, right? 19. Wow, good guess. So yes, that's around the time. All right. So polysomnogram, the type of EEG waves that we see here. So I just kind of want to review this a little bit. Stage 1, you have a lot of theta waves, and stage 2, you have your spindles, you have that K complex. Stage 3 is more of a slow waves here. We call it also what type of wave? Stage 3. Yep, that's right. And then with REM sleep, what kind of thing do we see? Sorry, sawtooth, right? So with sawtooth, it's, as you can see, just kind of remember when you look at the EEG, kind of go through it. It's got all of a sudden, a lot of times you go from stage 3 to REM or stage 2 to REM. But one of the big things that you could really see there is that dampening down of the amplitude. And I want that to be a pattern recognition first step. Okay, and then of course you look at the, the EMG of the eye and everything, but that's one of the biggest things that should probably jump out at you. Okay, it could be fast in terms of frequency or slow, all that stuff. So I guess I already gave away the answer to that, but this is a relaxed wakefulness, and then you're looking around, you have rapid eye movements, voluntary, some alpha waves there. And stage 1, you got more of a slow round eye movement, you got some muscle tones. And then stage 2, now we can probably pick these up pretty easily now, right? With the spindles and K complex. And sometimes the K complex, in my experience, a lot of times I look at the K complex, especially in the beginning. Oh my God, is that the spike and slow wave? Does this patient have epileptic forms and all that? So I don't know. Does K complex scare you? No, you're like, nah, I got the EEG part down. It's fine. I'm gonna kind of go from there. Okay, stage 3 sleep. We kind of see the amplitude still remains high because it's lower, and REM sleep, every time you kind of look at this and with the EMG kind of flattening out, those are big things. And some sawtooth, and as you can see, much higher amplitude, much lower amplitude. That's kind of like a pattern, if you could see that, that would be good. And kind of go from there. So some of the characteristics we already talked about with that table, that is, I would say at this point, it's probably pretty intuitive to you guys already, the muscle tones, like the arousability, and then the O2 CO2 control. How that is the lowest during REM is actually pretty interesting, and anyhow, with physiological regulation of sleep REM, sleep-wake cycle with age, increased wakefulness during sleep period, decreased stage 3, earlier timing, greater daytime sleepiness. Women have longer sleep, they have more stage 3 sleep, timing of the sleep is best at night, illness and medication, they all affect how you sleep, right? And I thought this was pretty interesting, where, you have a lot more delta waves, and obviously with that corresponds to a good stage 3 sleep, right? Delta, stage 3, delta, stage 3, delta, stage 3, and kind of going from there. 20-year-old woman versus a 71-year-old. You kind of missed out stage 3 altogether. Okay, they also have a shorter duration. However, that duration is still on average more than 7 hours. So if you look at that, sleep latency, WASO, and all that, so you're still, even at the age of 85, but back then, this is a study about 15 years ago now. But with stage 1, the proportion stays the same, but really, it's the slow wave sleep that diminish a lot more as you age, okay? So coming back to here, process C and process S. Process C goes on every single day, but your process S, basically, if you don't sleep, if you don't have that replenishing moment, it would just keeps on building up until you get that. But you see these different types of circadian like alerting signals and stuff like that. That helps to explain a lot of times why you have random second winds and stuff like that. Here and there, you're so tired for a period of time, and all of a sudden, it's almost like, oh my God, it's past 3 p.m. I'm awake again. But somehow between 1:30 to 3, you're just like, okay. And that's the worst time to read studies. All right, so we got that, which is kind of like a governing process that try to understand circadian process as well as the sleep process, how they kind of oppose each other to a point that you have you're trying to be alert and you become the least alert, and you have the sleep burden kind of coming down the strongest, and all of a sudden your alertness just drops because you fall asleep. You start replenishing, and that alertness starts building back up again. Okay, neuroanatomy and neurobiology, neurochemical control of sleep-wake states. We will get into that as a same topic together, which one of the big things, you look at that, oh my God, what are these things, right? That's my first impression, and still the same impression. And there is a good review articles that I really strongly recommend each one of you have a time, to read it. I'll send it out, or we can even just make a copy here. Back in 2008 by Jonathan Schwartz and Thomas Ruff. I also have something related to that later on in the slides here, but I tried to look up newer reviews on sleep neurobiology, but I still think this one that was done back in 2008 is probably still the most relevant to us, and then it just explains things pretty well. Okay, and it's very similar to the explanation in that textbook, Fundamentals of Sleep Medicine, by Richard Berry. That one, I think this is even more concise than that one. That one you do have to kind of refer to the figures left and right. Just could be a little bit confusing, especially when you start talking about VLPO. What's VLPO? Anybody can tell me what's VLPO? Right, and so it's VLPO, it's ventral lateral preoptic area, kind of, and then you have the LC, right? And then You have TMN, you have RAFI, and you have the orexin, which kind of turns on, gives you the awake part. And then the orexin kind of DOPO kind of sets out stuff to stop, tell everybody to stop. When that happens, then you kind of go to sleep. The flip-flop switch. Body is trying to find the balance of that flip-flop. You either asleep or you either awake. That middle period, that middle ground is where body does not want to go. Then of course, with the impairment of any of these places, that could make you fall in that brain fog state, possibly, and also that imbalance between wakefulness and sleep. And then that's the part that's the least fun. I mean, you're either asleep or you are awake. And patients are gonna come in to tell you, it's like, "Man, this feels like I sleep so dreaming. I'm awake, but it's as though I'm not awake." And of course, a lot of narcolepsy patients will tell you that. But I think there's just a lot more for us to know in neurobiology as well about sleep. But this is how much we know right now, and how much they knew back then also has something to do with how much we know now when they're trying to do different experiments. This one in particular, sleep-wake circulatory overview, and I think they were really focusing on some of the studies on trying to knock out some of these nuclei and stuff like that in experimental mice and everything, and then they ended up having not much difference. So meaning that the effect of norepinephrine and the effect of histamine and all that is not as great as one thought, at least in the mice model. So the main thing that drives the sleep is still the GABAergic neurotransmitters. However, going through this, look at the flip-flop switch. Who's gonna understand this? I mean, I honestly don't be like me, okay? Everybody is already logged off, so it's only between 3 of you and me. Don't forget to register for your sleep medicine board. Okay, so I will be taking my board the same time as you guys. Okay, because I freaking forgot this time.
Oh.
I couldn't screw up. But anyway, and then so busy with a lot of things, and then I found out, I was like, oh, I just registered. It's about 2 months away, right? July 15th. I was like, oh shit, I already passed the deadline by like 4 weeks. So
Did you not call API?
I tried.
I know someone who actually did that, but that was an exception because of visa issues, but they actually did.
Right. And for me, and I even asked Audrey to look into it for me because he writes the questions and stuff like that, right? So nothing. But so I'll be taking it at the same time as you, and we need to understand this when we take the board. I don't think we need to remember that much in detail, but again, speaking from the person who has not passed this board or taken this board, so take it with grain of salt. But here we go. Model of sleep-wake regulation relevant to insomnia, the ventral system, the dorsal system, and you got all these little things. Locus coeruleus, lateral dorsal, ponton, tegmentum. Leave that for the neurologist, right? What you need to know. TMN, temporomammillary nucleus of the posterior hypothalamus. But as sleep docs, we do need to know some about this. So I again, wanted to show these ones coming from all these different nuclei to help you to keep you awake. And going from VOPO, basically shutting them all down, and this is when you go to sleep. Okay. Speaking of which, I find it just like if somebody does it well and explains it well, why do I need to say it myself? So there you go.
Being sleepy is easy, so look at the dark blue VLPL, ventrolateral preoptic area. If I turn that one on, it's nighttime, I'm supposed to go to sleep, the light has gone away. Look at that, that was cool.
How's this? Oh. Okay, that sounds good, right?
Being sleepy is easy, so look at the dark blue VLPL, ventrolateral preoptic area. If I turn that one on, it's nighttime, I'm supposed to go to sleep, the light has gone away. Look at that, that was cool, right? This little pinpoint area sent little fingers and neurons to every other wakefulness center and said, knock it off. One little tiny part of your brain says, go to sleep. And it tells all those other wakefulness areas, 1, 2, 3, 4, 5, at least 6, 7 of them, to shut down. You're inhibited. I want to go to sleep. Do not wake me up until 8 in the morning. All right? So going to sleep tends to be easy when you think about the math of this. You're talking about one thing. And what else can we do? Let's make this daylight now. All right. Almost, there we go. Daylight. It's morning time. Your VLPO is making you be asleep. Well, we want to shut it off. The tuberomammillary nucleus, it's part of the switch, right? If VLPO is on, you go to sleep. If you switch it over to the TMN, you're going to wake up. Blue is histamine. Remember, antihistamine makes you tired, so promoting histamine wakes you up. So tuberomammillary nucleus turns on because it's morning. The suprachiasmatic said to do it. It turns the VLPO off. The sleep center can't turn itself on. You send histamine up to the front part of the brain to wake up your cortex. Life is good. Snooze alarm number 1 is hit, you're partially awake. Next, who's the next player? Let's see. So the VLPL disappeared. The lateral hypothalamus, hypocretin, same thing as orexin, same chemical, 2 different names. That turns on. This is kind of cool too. He's got little fingers and everybody else here, right? Going, wake up, wake up. So the orexin's job, the hypocretin's job, is to go to all those other wakefulness centers and wake up, start running. I call this the backup generator, right? If your norepinephrine falters, you get poked by orexin, turn back on. Serotonin disappears at 2 o'clock, orexin turns it back on. It's another little tiny nuclei, but it uses orexin or hypocretin. These are stimulating, arousing chemicals to wake your brain up. Basal forebrain lights up, so do the PPT and the LTD. This is acetylcholine. This is your reticular activating system. This is your arousal wakefulness system in your midbrain, right? So acetylcholine wakes things up, thalamus and your cortex. Ventral tegmental shoots dopamine everywhere. Dopamine's a wakefulness chemical, right? Remember, our stimulants, they're uppers. Cocaine, uppers. Why? Dopamine lives there. So the dopamine center comes on. The next thing, norepinephrine from the locus ceruleus comes on. That wakes you up too. And the raphe and serotonin wakes you up. Look at all these circuits it takes to be awake. One tiny little thing made you go to sleep. And it takes 7 to wake up, right? So again, if one of these things falter, you have backup systems. What if 3 go down? Now you're tired and sleepy. So again, if it gets dark again, the VLPL comes back on and says, hey guys, knock it off, go to bed. Right, and we've come full circle.
I found that little short clips pretty informative. Just looking at that, it's like, oh, this is where it's just the, histamine, acetylcholine, dopamine, and all that stuff coming from there instead of reading a paragraph form description. So anyway, I found this and I thought I was like, you did a pretty good job with that whole animations in the back and stuff like that. Why do I have to go through that? And still, after I talk about it, and they call it just saying. And I had no idea what I just said. You had no idea what you just heard. So, so with the REM on, lateral dorsal, all that with the acetylcholine, REM off, and all that stuff. So these are things that are there because the lateral hypothalamus was sending the orexins or not having the orexins, and that's where you start having your REM and non-REM. So guess what? The guy who wrote this, he happened to be on TV. So we're not there yet, but this is kind of like the map of kind of going from there. And REM on the REM off with the green dots, REM off with the red dots, and how it goes down to creating the REM matonia part. And we will listen to this guy, Thomas Roth, talk. And I found his way he explains basically the basics of this and how that leads up to narcolepsy. Actually, really, really concise and easy to understand. It's about 7 minutes long. And then after reading it, and I just found out that he's a paid advisor for a particular company. the company that give you the most jazz, right? What the jazz produce. So is that way? Sucrose down and stuff like that. So it's interesting, just like how that delicate relationship between the industries and clinics and stuff like that. But here we go.
I want to turn things over to Tom, who's going to discuss the neurobiology of narcolepsy as well as the pathophysiology. Tom?
Thank you, Jonathan. It's a pleasure to be here. And what I'm going to try to get to in my presentation is to understand the pathophysiology of narcolepsy. While very often pathophysiology is sort of an academic exercise, the pathophysiology is very informative because it really does explain many of the symptoms that my colleagues will be speaking about with the rest of this program. But before I can tell you about the pathophysiology of narcolepsy, I gotta spend about 5 or 10 minutes, about 5 minutes, talking about normal sleep physiology. In other words, what controls your sleep, what controls your wake. It is very important to understand that if you sort of look at the slide in front of you, you see on the bottom there's a switch. And Dr. Saper developed this idea, which has tremendous heuristic value and is used in the sleep field all the time, this idea of a flip-flop switch. So in other words, sleep and wake are a flip-flop switch. And what we mean by that is sleep inhibits wake and wakes inhibit sleep. So here's an example of that. So hopefully everybody where you're sitting tonight, you're wide awake. And hopefully while you're wide awake, this is what your brain looks like. And what we have coordinated activity with a variety of ascending arousal systems up to your cerebral cortex. Okay? And these are excitatory transmitters. And many of you, based on your background, understand what these are. So things like acetylcholine, dopamine, histamine, norepinephrine, serotonin. These are the transmitters which keep us awake. And what you can see is they keep you awake, but very importantly, they inhibit the sleep system. So in a normal person, in a normal individual, after about 80, 90 minutes, there's a change. And we can talk about what that changes. But what changes is the sleep system takes over. And the sleep system is governed by a single neurotransmitter, primarily by one transmitter, and it's the GABA-A system. It is located in the ventrolateral preoptic area, and the sleep center of the brain is the VLPO. So the VLPO does two things. It puts you to sleep, but very, very importantly, it inhibits all of those waking transmitters we spoke about a minute ago. Now, to sort of facilitate this flipping back and forth, so think of it as a seesaw, and what sort of triggers you to go from one side of the saw to another is this wake-promoting neuromodulator. And very specifically, it's something we in the sleep community call hypocretin. If you read the medical literature, as many of you do, it is often referred to in the literature as orexin, and it's called orexin because it was originally discovered when people were studying obesity research. But what they found is hypocretin, and there's two variations of it, hypocretin 1, hypocretin 2, okay? A wake-promoting is a neuromodulator, okay? It is synthesized in a small group of cells, and that's very important. We'll talk about it. So all of this hypocretin is synthesized in this small group of cells in the hypothalamus. But it has tremendous projecting, ascending to keep you awake and stimulate all those other transmitters, and descending in terms of motor control we'll talk about. While we're going to talk about this tonight in terms of narcolepsy and sleep-wake control, it also has profound effects on appetite, motivated behavior, substance abuse, potentially depression, lots of things. It's a very important transmitter system. Now, hypocretins, our current hypothesis is it has as its job the stabilization of the sleep-wake system, okay? So one of the things it does, it has transmitter systems going up, and what it does is the arousal systems, it arouses the cerebral cortex, and very, very importantly, in doing that, it promotes wakefulness, but equally important, it inhibits REM sleep, it prevents REM sleep from occurring, and it helps you maintain motor control, so you have full control of musculature throughout your waking period. Okay? So, this is that flip-flop switch that I told you about, that seesaw. In a normal, healthy individual, in normal wakefulness, wake-promoting neurotransmissions may promote cortical arousal, and you see the list of them there. Wake-promoting neurotransmitters may inhibit sleep-promoting neurons. That's what they do. You can see, besides keeping you awake, they inhibit the sleep processes. And hypocretin is the stabilizing neuromodulator which flips this back and forth. Okay? Now, in normal sleep promotion neurons inhibit wake neurons, decreasing cortical arousal. That's what happens in the sleep system, as I mentioned before. Now, as I mentioned, hypocretin has other functions, and one of them relates to REM sleep, and REM is very much involved in the control of muscle activity, okay? So it originates from LDT, PPT, very simply put, pontine nuclei, and the increased thalamic activity, which gives a lot of the activity we have, but very importantly, it has descending things down to the spinal motor neurons, which inhibit activity in sleep. So in REM sleep, all of us are paralyzed for roughly 110 minutes every night. Now, very importantly, hypocretin inhibits that. Okay? Now, hypocretin, as I just mentioned, activates histamine, norepinephrine, serotonin, and it suppresses REM sleep. And all of those things together prevent you from having REM sleep and REM-related atonia. Now, so in a normal individual, in a perfectly normal, healthy individual, we have this histogram. You start roughly at 8 o'clock at night, and there's the next 24 hours. They're awake for about 4 or 5 hours. They sleep for 8 hours, and they're awake for another 8 hours. But that switch works well, so so you flip between sleep and wake, and you make those rapid transitions from one to the other. Sleep disorders, narcolepsy is about when those things are not stable. So wakefulness, sleep, wakefulness. And you can see within the sleep period, we flip-flop between REM and non-REM sleep. In humans with a 90-minute cyclicity, this person, for example, woke up twice. But other than those two awakenings, they asleep for 8 hours, they're awake for 16. Okay, so to sort of summarize very quickly, normal sleep, wake switch, the primary transmitters are histamine, norepinephrine, serotonin, dopamine, acetylcholine. And, I'm not going into neuroanatomy, but like, for example, histamine comes from the tubermammary nucleus, locus coeruleus is very involved. Now, in contrast, there's a single transmitter, GABA-A, and that's the sleep-promoting system. And again, hypocretin is a stabilizing modulator. REM sleep, very importantly, is inhibited by hypocretin and the other wake-promoting transmitters, very specifically norepinephrine and serotonin.
All right. I thought he really knows what he's talking about. That's the way it goes with the ascending arousal systems and also descending control of the motors. Understanding the neurobiology of it, so understanding the 5 neurotransmitters, and of course that goes into a lot of what these medications do, right? Why people, when we review the amount of medications, why potentially these medications or the medications related to these neurotransmitters could potentially cause sleepiness. But again, even serotonin, even histamine, the H1, H2, H3 receptors, like which one is which? Are you, love of God, are you kidding? Just like there's more to it, however, but especially at this stage and also going forward, we gotta have a big general idea of what these neurotransmitters do. GABAergic ones. I was like, okay, makes sense, And then antihistamine, what is it push to sleep? Oh yeah, it makes sense. But antihistamine is one part of the 5 that makes you go to sleep. I mean that keeps you awake. So you knock one out, what are the other 4? So those are the kind of ideas. So if you can remember sleep center breath is VLPO, and then remember the neurotransmitters, the 5 different kinds, main thing, and obviously the sleep one is GABA driven, and the neurotransmitter being orexin, then I have done my job today. And yes, your eyes are all telling me you just remember what I just said, right? Okay, good. All right. So EEG, we got this physiological activities, eye movements, we know that, muscle tone, LDP, PPT, of course, that is where we produce the REM, right? And then for the life of me, I still can't really memorize all those acronyms or abbreviations of what they are, but before the board, just make sure you remember them.
The pontine.
Yeah, pontine, like tragmentin or something. Okay, Netta, help us out. What's LDT?
Lateral dorsal.
Close You know, it's like, you know, I mean, those ones, you know, quite honestly, just make sure you remember them before the board. And that's all we need. You kind of know what they are, you know, that's good because they're the REM producing, right? And these ones are, you know, different different nucleus that produces different neurotransmitters, right? So they keep you awake, and VOPO, and then there's a VOPO extended. Oh my God, like EVOPO. I'm just like, seriously, you know, and the hypercritin, obviously, you know, you want that. And one of the interesting thing about hypercritin is that narcolepsy patients, and when you see them, and a lot of them have insomnia at the same time, and you're like, what do you mean? You are, by definition, too sleepy. What do you mean you can't sleep? But true narcoleptics, they are like hypocretin. So they cannot modulate very well or stabilize between sleep and wake. So they pop up and pop off, pop on and pop off. That's very, very debilitating, right? And they have an inability to fall asleep because the hypocretin is not there. The VOPO is trying to go at it, but then the hypocretin is not there to stabilize the on and off switch. So they have problem going to sleep, and they have problem staying asleep as well.
That's why we switch.
Exactly. Yeah. However, and I believe that's exactly how Xyloto in the way it works, and why you needed a 2-time-a-night dose, kind of getting it out. But then going forward, they have this once-a-night dose, which apparently I just found out that it's not a jazz medication. And you know why they have Xyrem and now on Xyrate? Obviously low sodium, right? It's a low sodium. Exactly. Yeah. Like the Xyrem patent is about 22 years now. You know, just keeping something, and then they just found something. It's like, you know, it is significantly better.
Magnesium.
Yeah, something like that. Whatever. You know, so this is kind of the game, right? But the thing is, for us to understand the science, ultimately, really, we should, you know, use whatever we know and whatever we have at our disposal to help better help our patients. Okay, so neurochemical control of sleep-wake states. Acetylcholine, they're from there. What do? Histamine, they're from the TMNs, posterior hypothalamus. They keep you awake. GABA from BOPO, okay? Serotonin, Raphe. Norepinephrine, locus coeruleus. Is that right? What? Ceruleus. Okay, very good. And hypercritin, lateral hypothalamus. Okay, so we got all those, you know, LC, RN, whatever, you know. I love brain in a way that I'm so afraid of it. So neurochemical control of sleep-wake states, again, dopamine, adenosine. Adenosine is another interesting thing that we used to think, but it still plays quite a bit in terms of our sleep-wake state. Nitrous oxide, cytokines, prostaglandins, hormones, melatonin growth hormones, and all the other stuff. Delta sleep-inducing peptides, and going from there, integration of sleep-wake states and circadian rhythms, you know, just kind of glance at it and be like, oh, cool beans, you know, basically light comes in, retina, and transmits to the suprachiasmatic nucleus. Am I right? Did I see it? I've been like looking at, I was like, did I say it wrong? I don't know. I'm like, right? And then, you know, with all that and then producing melatonin and, you know, going on. But obviously that all goes, I mean, that's kind of more like an initiator, like a signal coming out. And then your body, every part has to work together to kind of make that happen. But obviously with VOPOs, really at night, that really shouldn't have a problem sending it out. But, you know, if you lag GABA for some whatever reason, that insomnia might come in, and that whole other stimulus. But that's for the neurobiology related particularly to insomnia. That's a whole different ballgame that we could probably talk about. That I would ask, what's his name? Come on to talk about it.
Where does like melatonin come in? And where does it act?
All right, there we go. Aha, 1 second. Melatonin is my next slide. So cue for sleep, you know, circadian, Then you got light, food, social, melatonin, adenosine, and all that. So light, here's what we're talking about. So melatonin and biological clock, right? So melatonin is produced in the pineal gland. Okay, so it's right there And with this, the lights from the SCN, where it controls really your circadian rhythm coming down here and all that. So the peaks is proportional to light, which happens to be 24 hours, and then also light at peak levels produce rapid suppressions. So that's why light therapy works in the mornings when you try to shift people. You have that light therapy, you have a positive of light coming out a certain wavelength, and white melatonin really is there controlling the clock. And I want you to think about this back to the sleep and circadian rhythm, right? Melatonin is trying to move that S curve somewhere, but does nothing to, in particular, to the VLPO, that part which puts us to sleep. So that's why we always say melatonin is not a good hypnotic. It just helps your body to kind of find that balance between your alertness as well as, that process C and your process S, and just to move that clock around. That's really what melatonin is. Okay. And in the middle of the night, I still haven't found a good study on the extended release melatonin. I've heard good things about it, but what it really does is like, why do you need to keep on shifting your clock? That's a little bizarre to me still, but the general thought is that melatonin, again, is not a good hypnotic. It doesn't work on those places, but it's a good clock shift. Okay, and that's what it really does, to work on the circadian process. And I just had a patient who is, always saying and all that, a whole bunch of, psychiatric issues and all that. She told me, oh yeah, I take melatonin, I take some of the gummies. And I was like, okay. First she told me the gummies, and I was like, what the gummies you taught me about? Then she said melatonin. I was like, okay, cool. The 2.5 milligrams. She said, yeah, I take 2 of them. So okay, it's not bad. And then I also take 3 of the 10 milligrams. And I was like, wait, what? And then somebody said she had 35 altogether, right? 35. So I was like, and she said, this is the only combination that works. I was like, really? Have you tried like 4, like 10 milligram ones? And she said, no, that doesn't work. It has to be 3 plus 2 gummies. I was like, perfect. And then I was like, and then she looked at me and she's like, Doc, I just want to be totally honest with you. Okay? And then I was like, I also want to be totally honest with you. I think this is 120% placebo. And then she looked at me and I was like, yeah, you want to be honest? Let's be honest, right? I use 30 milligram melatonin to treat something else. So I use that to treat rare behavioral disorders, which you don't have. And then she's like, yeah. But this combination works. I was like, that's fine, whatever works, And then, if we kind of go over the hump and challenge their beliefs and stuff like that, we can work on that. That's just kind of like how I approached that one case in particular, just recently in the last 2 weeks. So when I heard that, I was like, it has to be 10 milligram melatonin plus 2.5 milligram gummies. Has to be that.
No, you told her that it's not.
So we'll see. Exactly. We'll see what happens. Speaking of which, one of the patients said, oh my goodness. So sleep and hormones, I'm not gonna go on this, go into the details. There's effects on many different hormones, LH in women, and growth hormones, especially in kids, ACTH, cortisol, prolactin, they are all greatly affected by sleep, okay? And we can get into that why and all that. So, and then we, of course, being a sleep fellow and being a sleep physician, sleep is important, and it affects to a lot of different things, and maybe we can get into those for different particular separate audience, and all that. So, and quite honestly, feel free to even reach out to whatever programs that you can, and probably even offer to get lectures to, on very basic sleep topics. I think those does help you going forward, because they know you, they're always looking for presenters, residency programs, and all that. And I had done a few during my fellowship, and that was not. I feel like that was okay. And whenever you get to prepare a lecture like this, you're actually the ones that's reviewing heck a lot of stuff. You want to make sure you do a good job, and then you learn the most from there. And I definitely do encourage. It's probably not gonna be like easy to say, hey, right here, family medicine residency, internal medicine residency, getting you guys to go out there, maybe one of you, maybe. The thing is, with now the green rounds and all that stuff going in, like Zoom and all that stuff, everything become, a lot of things become feasible. And I think those are great opportunities, not only for you to gain more knowledge and be more solidified in what you have learned so far, but also a good way to build up your resume too. That way, having your stuff. Just some thoughts, okay? And thank you for your attention. Any questions? Not allowed too many. If you say no, great, that's good. Any questions at all?